Hi, everybody. It's Dr. Sandy Kramers, and a friend had asked me to do some research for her son who had a horrible accident where a stick went into his eye when he was roughly around 7 years old or 6 years old, and has had some surgeries to remove the traumatic cataract, of course, repair the ruptured globe. But the good news is that the cornea looks good, the retina looks good. So the question is, the patient doesn't have their capsule intact. And so what we're talking about is a traumatic cataract. So a cataract is like a pillow in a pillowcase. And so when the child had this stick into the eye, it damaged probably the anterior capsule, the front part of the pillowcase, the pillow, the cataract, or formed a cataract very quickly, and even the back part of the pillowcase or the capsule. When we do general cataract surgery, we basically remove the cloudy pillow and put in a new clear pillow. And the back part of the pillowcase keeps that new pillow, intact, safe, and stable. If a patient has had rupture to the capsule, which can happen in cataract surgery, and especially if you've had trauma, the whole capsule complex, or the pillowcase complex, we could say in this analogy, has been damaged. And so in a child, the question is, what's the right time to put the implant in? And it's been a question for years. When I was trained, we would generally wait till the child was old enough that the eyeball stopped growing, so the implant wouldn't have to be changed again, which is a pretty traumatic surgery and very risky. So now the question becomes, well, has technology caught up that a patient, even at the age of 2 or 3, should have an implant put in? Because what happens often is, because there's no implant, the glasses are either super duper thick, or the patient can't tolerate a contact lens, and their vision starts to decrease because they don't see very clearly because of blur. It's blurry on their retina, which means it's blurry in their brain, and their brain never learns to develop good vision. So it's a race against time. If a patient has astigmatism, meaning the front part of the cornea is irregular and they can't correct the vision to 20/20 with contact lenses or glasses, or the patient can't wear contact lenses, which a lot of kids cannot, then the brain will never learn to have good vision. It's not the end of the world. I have many friends that only have one good eye, or have a very lazy eye, even if they don't have crossing of their eyes or strabismus. It's not the end of the world. So I tell people, don't stress out about this. But if we can, of course, improve the vision, we want to. So the studies indicate that sooner surgery is better. And it really depends a lot on the actual patient, the data points. It depends on the surgeon, the experience of the surgeon. So finding a great surgeon is crucial, which is difficult sometimes, because if you're in an area where you don't have an academic medical center, it can be hard to find a good surgeon that has a lot of experience with this. But they are definitely out there, and I highly recommend finding a good surgeon and asking them these questions. How many secondary IOLs have you done? What is the average age of the patient you have treated? Trying to kind of maybe indicate you don't want a resident or a fellow doing most of the surgery. That's a little trickier one if you're at an academic institute like Harvard or Johns Hopkins or even Georgetown, or Bascom Palmer. Those are the best places in the world to have this done. But there's excellent surgeons around the country. So let me just quickly go through some recent papers. Excuse me as I read this, but this will kind of help. So a couple of recent papers. There was one in 2024 in the Journal of Children. It was called Neural Network-Based Prediction of Postoperative Visual Outcomes Following Secondary Pediatric Intraocular Lens Implantation. This is what kind of the paper you want to see. And basically the idea, it's a retrospective cohort, meaning it was done not going forward, but it was looking at their old records. And the basic idea is that, yes, it showed there were better outcomes when you had the surgery done a little bit longer. Let me just read this because it kind of helps indicate what we should do. So basically it showed it used a neural network to predict postoperative visual acuity based on age at implantation, noticing the pre-op vision, ocular comorbidities, what are the risks, and the timing. It showed that better outcomes were associated with older age beyond infancy, but not with prolonged delay once the child was school age, which is really around 6 years old. Emphasized that amblyopia therapy and stable ocular anatomy are crucial. They concluded that secondary IOL is a standard option for visual rehabilitation in appropriately selected pediatric aphakia, meaning you don't have a lens, once the eye is quiet and structurally stable. So once your past 5 or 6 years old, I think it's probably the best thing. Even knowing you might need a second surgery down the line, the surgeon's going to talk to you about the power implant, the power of the lens to try to help match it to the growing eye. They're going to tell you to still do the patching to make the eye stronger. They're going to tell you to minimize screen time if they want the eye not to grow too quickly in terms of length. If they want the eye to grow more, they might have you do a little bit more near work to make the eye grow if your child is 7. Okay, that was 2024. It was done, and I'll put this all on my my blog, the iDoc 2020 at blogspot.com. I'll put that in the link. And this was done by a group in McGill University, Dr. Farah, Dr. Fahar, who might be a resident or fellow, but it was published. And then the second paper was done in 2022, Seminars in Ophthalmology. The title is Secondary Intraocular Lens Implantation in Children, What, Why, When, and How. This was done by a group in India, and the punchline is to avoid it in infancy because the eye is still growing, which is still standard of care. Most people don't put an implant at infancy, but they did say after the age of 2 or 3. After, it says 2 or 3 years, but I think they mean school-age children. So probably around 5 years of age. And do not delay it for many years if the eye is stable and there's no inflammation, to prevent irreversible amblyopia, because amblyopia, lazy eye, is irreversible, very hard to undo. Okay, last paper here I'll mention was done in India also, and it's called Secondary Implantation at Pediatric Age, and the conclusion was children beyond toddler ages, especially if there is the eye's quiet, everything else looks good. A scleral fixated, meaning they take suture and they actually use a needle to attach it to the wall of the eye, which is probably the best. The second option is iris claw, where they take the lens, actually has a claw to hold on to the colored part of the eye, but that has a little bit more risk. So sutured IOL is the best. It's the most stable. There are risks, of course, and the doctor will always tell you the same risks. Risk of losing the vision, losing the eye, the child's death, the surgeon's death. Those are incredibly rare, and most often it does work. The vision comes back. The vision may not be perfect, but it's usually very good, even to have depth perception. But even if it doesn't go well, even if something goes bad, we have had many patients and even friends and neighbors that only have one eye, and they do great. So just be aware to not let it stress you out, because it's a hard decision. It's very scary when it's your own child. I totally know this. But the technology is amazing. There are amazing surgeons in the United States and even around the world. So I hope this helps. Take care.